Thank you for joining McLaren Northern Michigan today for the last presentation in our four-part virtual orthopedic education series. Today's session is being presented by Dr. Christopher Kennedy, foot and ankle surgeon. Dr. Kennedy will share solutions when ankle pain is holding you back. For the duration of the presentation, all participants have been muted. If you have questions, we encourage you to submit these using the chat feature. These questions are only visible to the moderator. Dr. Kennedy will share his information and then we'll answer questions at the end of his presentation. For additional questions, to schedule an appointment, and for follow-up information, we encourage you to use the link that will be found in the chat box. All registrants will receive an email follow-up that will contain this link as well. Thank you again for joining us. Now, without further ado, Dr. Kennedy, please talk to us about ankle pain solutions.
Thank you very much for that kind introduction there, and good afternoon to all of our viewers here. Thanks for taking the time out of your day to learn a little bit more about your health and hopefully some of the tricks that I have to get you back up and walking and getting on with your summer in a pain-free fashion. You know, I think there's a little bit of confusion about what the ankle joint actually does, and it's confusion because it's a confusing, complicated anatomy. The ankle joint itself is made up of three osseous structures. It's the tibia, the fibula, and the talus. Those are bones that create this U-type structure and allows for really simply sagittal plane motion. That's up and down motion of your foot in the same plane. Those structures, the articular structures there are highly faceted, meaning there's multiple different surfaces that interface with each other. It's a relatively low surface area, so it has a higher pressure force than the other weight-bearing joints in the lower extremity, and it's absolutely prone to injury. There's another joint in the rear foot just underneath the ankle joint. This is underneath the talus bone, this bone here in the central foot on the x-ray. It's called the subtalar joint. This allows for frontal plane motion of the foot. And I only bring it up because it can mimic ankle pain and be a source of what feels like ankle pain, but in a completely separate articular surface, a completely separate joint. Of course, you know, we look at the osseous structures, but there's really an extensive network of soft tissue in the ankle. That's in the form of ligaments that we're seeing there on the left that build these large cuffs around the articulations that form the capsule of the ankle. These are static structures. These are restraints that prevent dislocation. They keep the foot and ankle in line, but they don't move. They have no muscular component. And we also have tendons. Those are what you're seeing there on the right. These are like ropes on the end of the muscle that act like pulleys. This is what's actually controlling motion of your foot and all the different planes. And you can see it's extensive, both on the ligament and on the tendinous side. This is where it gets kind of challenging sometimes for diagnosticians and surgeons. There are all these discrete anatomy points, all the articular surfaces, all the osseous structures, all the ligaments, and all the tendons can all be points of pain depending on the complaints. And it's important to figure out, or at least to do a thorough diagnostic workup to try to figure out what the etiology of a person's complaints are to appropriately treat it. Of course, overuse of those ligaments or tendons and even the osseous structures in the form of a stress fracture can cause pain. Wear of the articular surfaces in the form of arthritis or degeneration can cause pain, and absolutely acute trauma in the form of a sprain, a strain, or as what we're seeing in the top corner there, and in terms of fracture. Those can all be sources of pretty extensive pain in the ankle. These are the guidelines I have when I recommend evaluation for patients. If you can't walk on your ankle or on your leg because of ankle pain, that's absolutely an indication. That's usually associated with a rupture of a ligament or tendon and very commonly associated with fracture. Pain that maybe you have a misstep or you've got a slight roll of your ankle, pain that doesn't resolve or progressively get better over the course of just a few days, that usually warrants further workup. Any pain for the athletes out there, any pain that's limiting your ability to compete, and for the entire population, anybody who's being limited in the activities that they want to do, they feel like their ankle pain is holding them back, and that's true for the foot as well. That's a good time to see a provider. And of course, if you are experiencing chronic ankle sprains, if you have any sort of crepitus sensation in your ankle or joints at the lower extremity, that's another indication for evaluation. Sometimes that can lead to additional injury and result in fracture or complete rupture, possibly even additional cartilage damage that's usually reversible. It's nice to catch those things early, treat them appropriately, and get you back on with your activities. With any musculoskeletal exam, the basis of a visit is based on a history, what your complaints are, where the pain is located, and a thorough clinical exam looking at the mechanics of your foot to actually lay hands on the joints and get a good feel for range of motion and tenderness palpation points. In our clinic, we have an on-site, that's the McLaren Northern Michigan Orthopedic Services Clinic here at the hospital. We have an on-site dedicated radiology suite so we can get instantaneous digital read x-rays, which are very thorough, high definition x-ray reads. That's what we're seeing up there in the top right corner of our screen. This gives us a good look at the 2D structure of the anatomy and the osseous structures. Sometimes that's just not enough to really work up these delicate, discrete intrinsic pathologies. So we need to pull to some advanced imaging. That's in the form of MRI, CT, or ultrasound. And MRI allows us to see 3D, the soft tissue structures within the extremity. This is looking at tendon ruptures, ligament issues or ruptures. It can also evaluate arthritis fairly extensively. It's a great tool. It's not indicated for everybody, but it's a great diagnostic tool. Occasionally we'll order a CT scan. That's a 3D view of only the bone structures. It's essentially a 3D X-ray, and we can get a reconstruction like what you're seeing in the bottom right corner. Also, occasionally an ultrasound is warranted. All of these are non-invasive, pain-free, easy testing to really dig into discrete pathology in the foot, ankle, and throughout the body, really. Treatment options are always staggered, conservative, and surgical for the most part, although sometimes severe injury can push the surgical indications quite immediately. For conservative therapy, I like to start with at least good foot health, and I do those with the 3 following things. We've talked about this before. These are for people maybe with a little bit more chronic ankle pain. This is what you need to do ideally to support the foot, to support the ankle, to correct early generalized mechanics. This comes in the form of a good quality shoe. I recommend a running type shoe, somewhere in the $75 to $100 range. Usually contains the technology that you need to support the foot. A supportive functional orthotic, that's something with a rigid arch. These are the 2 that I most frequently recommend, but there are any number of over-the-counter functional orthotics out there. This is to correct some of that frontal plane motion within the foot to try to balance out how the ground reacts to how the ground impacts into the extremity. And the final thing is simply calf stretching. In the US, we have a very not sedentary population, but a population who sits for usually prolonged periods of time. This allows contractures throughout our posterior compartment of our legs, including the thighs, the hamstrings, the calf muscles, and the plantar fascia. Simply stretching out your Achilles can increase range of motion, can go a long way of reducing pathologic mechanics, and it's a great part of just generalized good foot health. For people with acute or more acute injuries, we go to the RICE acronym. Rest is easy and elevation is easy. Icing, on the other hand, there's some misconceptions about. My preferred method is what we're seeing there in the top right corner. This is what I recommend to my athletes and extend that to my entire patient population. That's a paper cup that's filled with water, frozen in the freezer, and then you tear the rim of that off, and you massage that ice cube right into your focal area of pain or identified pathology. That wet interface, I find, really conducts the thermal energy of the ice, really brings the maximal benefit of icing to immediate inflammatory reduction following an injury. Another overlooked but subtle intervention point is just in the form of a compression brace. These don't really provide much support, and they definitely don't provide much functional support. But a lot of times, patient reports just a satisfactory feeling with having compression on their ankles. There is scientific evidence to back a compression ramp like what you're seeing there. It increases your brain's ability to sense the position and location of the joint, of the ligaments. We call that proprioception. So it's absolutely beneficial and a lot of times worth trying. I do want to talk about just a couple of the surgical procedures that I can offer. Not that this is indicated for everybody. You've seen the myriad of different anatomic points that there could be a pathology within. But ankle arthroscopy is an arthroscopy in general is a great diagnostic and therapeutic tool. This is a minimally invasive type procedure where we're using somewhere between a 1 millimeter and a 4 millimeter camera, putting that inside of the articulation, in this case inside of the ankle joint, to visualize the structures, the articular structures, a lot of times the ligaments, and thoroughly diagnosing and working up any sort of pathology that may be in there. A 1 millimeter camera is just larger, is just a little bit bigger than a large bore needle. So it truly is a very minimally invasive procedure. In the event that there is pathology found, or if there's planned pathology to be corrected, we can introduce a number of different tools into the ankle, also minimally invasive, through safe anatomic locations. This can include picks, graspers, and even mechanical shavers to resect, like we're seeing in the pictures here, extensive synovitis. Sometimes there's fibrous bands. Sometimes we can even do reconstructive repairs within the ankle to stabilize instability, lax ankle joints and ligaments. And finally, I want to touch on a total ankle replacement. This is really for people with end-stage arthritis, pseudo-fusions of their ankles, and sometimes for people with very extensive articular injuries. Ankle replacement is beneficial. It replaces the articular surface of the bone with a metal implant, returning range of motion, but also returning pain-free gait. There's a number of different implants out there, and they're not as prevalent as total knee or total hip implants. Those have been out for decades. Total ankle has really come to light in the past, call it 15 to 20 years, and continues to evolve into a very exceptional implant and very highly reliable surgery. There's a number of different implant systems out there. One of the things that I specifically like is patient-specific implants. What does that mean? That means implants that have been 3D printed, custom made for your unique anatomy. Everybody is different. There are intrinsic changes between every ankle. The implants, I feel, should match your unique body anatomy as well as the instrumentation. So we take a CT scan preoperatively if we're planning to do this kind of surgery. We take a CT scan, we send that to the engineers of the device manufacturer, and very similar to the structural engineering of a house, there's structural engineering of the cut guys with section tools and implants themselves that are then custom made. They're printed on titanium and then shipped in specific for your surgery. I think this really allows us to dial in mechanics. It's a lot of times indicated for these very severe pathologies. And I think the patient satisfaction coming out of this absolutely warrants the extensive workup. Overall, ankle pain is something that's prevalent. A lot of people come to me, they said they had ankle pain for years and are just now trying to address it. I'd encourage you to get seen, get hands on your ankle, try to get a thorough workup. Let's figure out exactly what is causing your pain, what's causing you to not be able to perform your activities. And let's try some of these conservative things. The three that I mentioned there, along with some other discrete interventions, can sometimes restore you to pain-free gait without any sort of surgery and prevent you from further damage of the surfaces of the joint and or of the ligaments and tendons. So it's absolutely warranted, and the sooner is the better is really with one of those. I think we have some time for questions here at the end of this.
Yeah, thank you. So one of the questions that came in ask about different grades of ankle sprains. Are some worse than others?
Absolutely. There's a grading system for ankle sprains, and you've often probably heard about a low ankle sprain versus a high ankle sprain. The grading system is provider specific, meaning come see us and we can evaluate you and we can give you a thorough grade on your ankle sprain. Whether it's a high ankle sprain or a low ankle sprain also requires kind of some really detailed diagnosing. A high ankle sprain is of the ligaments and structures that help support this U shape in your ankle. There's a pretty extensive network of ligaments in the front and then the back of this articulation between the fibula and the tibia. A strain, a rupture, a sprain of that would be considered a high ankle sprain. A injury to the lower ligaments, these ligaments that run on the side of your ankle and help support the medial and lateral walls of the ankle, that's considered a low ankle sprain.
Thank you for that one. Another one that came in states that when this individual walks on an incline, they hear a clicking noise in the ankle. No pain, only the sound. Is this anything they should be concerned about?
It's a little challenging to do a Zoom generalized diagnosis. Clicking and popping is one of my indications for evaluation. Usually that's a pretty easy, non-invasive workup that we can do to come to the etiology of that complaint. I would suspect either between just a clinical exam and plain film imaging, possibly MRI, we could easily identify the issue there. It does highlight a good point. If you are planning to be evaluated, if you're seeking workup, pay attention to the pain. Pay attention to things that cause the pain to be worse, cause the pain to be better. The specific location of the pain is very helpful. If it's in the front or back of your ankle, and especially stairs. Does their pain going upstairs, downstairs? Is there pain on an incline or on unstable surfaces? All those details in your history can be helpful for the physician or diagnostician to evaluate your injuries.
Okay, we'll take just one more here. And this one is asking about ankle ligament tears. Do they heal on their own, or is it best to always get it checked out?
Well, if you have an ankle ligament tear, I'm not sure how you know you have an ankle ligament tear. So yeah, it's probably worth getting checked out, especially if it's not resolving, if it falls into the criteria that I presented there for evaluation. A complete rupture of the ligaments on the inside and the outside of the ankle, if left neglected, can heal in a elongated position and result in sometimes chronic ankle sprains or a feeling of instability within your ankle. Usually at that point, there is no conservative intervention to reef up that tendon, to get it to heal in a shortened position to help stabilize your ankle. Intrinsically, there's extrinsic things we can do, like bracing and sometimes physical therapy, just strengthening the musculature around the ankle can help support instability. But no, a stretched out ligament, ruptured ligament in that sense is not going to heal on its own necessarily.
Thank you, Dr. Kennedy, and thank you for joining us today. Just a reminder, there's a link in the chat box to submit additional questions or request an appointment with Dr. Kennedy. This link will also be sent out to all registrants via email along with a recording of today's session. We encourage you to join us again for future educational offerings at McLaren, Northern Michigan, where we're always doing what's best. Thank you.